Alright, so this chapter is going to focus on Chapter 35, anxiety disorders. So to sort of we begin again with the pharmacotherapy of sort of anxiety is, we had talked about in the previous videos that sort of some sympathomimetic sort of activities or sympathetic arousal, it can sort of explain a lot of things. In this particular case, anxiety is going to be, for all purposes, can be considered to be sort of a sympathetic sort of arousal. So I mentioned in the bipolar video about the GABA sort of being a overall sort of inhibitor. So it's going to make sense that if your sympathetic system is riled up, much like it sort of was with bipolar, that GABA may be a useful thing to sort of calm the system down. So one of the primary interventional things for anxiety is going to be GABA agents. All right. So a couple of things to think about. In terms of anxiety is the different types of treatment for that. So you've got benzos, which really are going to be reserved for emergency anxiety, sort of acute anxiety. Understand that benzos, when they were designed, were never actually designed to be chronically used. They are now, because I think there was a lot of success with those medications, but they were really designed, they were not designed to be given out years and years and years. It's actually pretty bad for the brain, which kind of makes sense because if you're always suppressing everything, if there's always GABA present, and you think about the stuff with memory and attention, sort of things we briefly covered in some of the other videos, is if your norepinephrine's low, then it's kind of hard for you to learn, right? Because part of what helps us learn is that proverbial bell curve. So as it moves up, you're learning, then you kind of peak out, which the peak out point is the point of anxiety. But if those chemicals aren't present in the brain, everything's GABA, everything's calm, then you're not going to be as attentive to sort of your surroundings. Think about the combination between alcohol and benzodiazepines that they call roofies, temazepam. So what the main effect of that is amnesia, right? It's complete memory loss because there's an extra GABA. There's a lot of GABA being sort of produced. So in its extreme form can cause amnesia. So it makes sense that if you're exposing your brain chronically to GABA, that there's going to be some memory or learning impairments that go along with that. So the reason why I bring that up is the main thing in terms of benzodiazepines is going to be cognition, because too much sort of begins to suppress your entire system. Too much parasympathetic activity in terms of respiration, heart rate, and things like that. So one thing that I want to sort of mention regarding benzos and barbiturates and things like that, and I think this is probably a good place to sort of discuss that, is sort of how they work. But so we know that with benzos, if you take too many, yes, you can OD on benzodiazepines if you take just a ton. But what usually happens more often than not is going to be that you actually go to sleep before you can actually OD on that, because it's actually very, very difficult to do because of the way that they recept. So benzodiazepines they recept allosterically. So if you're looking at as this right here is sort of as a receptor, then allosteric would be something like right here. So it actually recepts next to the actual GABA receptor. So there's only a minimal amount that it's actually going to be able to produce. Right? Alcohol does the same thing. It's sort of an allosteric reception, in that it recepts close to the receptor. It only produces a set amount. But so with alcohol, if you drink too much, you're more likely to pass out before you actually want to die. Now, of course, you can get alcohol poisoning, you can aspirate, but those things are unrelated to the GABA. But if you were to combine the alcohol and the benzodiazepines, you get sort of a double GABA effect, and in that form, it is actually lethal. All right. So the reason why I bring that up is that what makes barbiturates so lethal is the reason why you have to sort of watch them is they have a very, very narrow therapeutic index, but they in themselves actually produce a double GABA effect. So not only do they recept allosterically, but they also recept within the receptor, they actually produce and they cause endogenous GABA to be secreted, and they also can mimic GABA. So there's a double GABA effect with that, which is why in isolation you can take too many barbiturates, you can actually OD on them and die. Whereas with alcohol and benzos separately, that's not really, it's very, very, very unlikely for that to happen. again, I just bring that up because I think it's important in terms of understanding sort of the GABA and the mechanisms that go along with that. So if you were to talk about sort of these GABA-like sedative hypnotic medications, like your Donestas and your Zolpidem, they're similar except for they actually affect a different GABA receptor, a GABA-B. So the difference between that is that you in the same way you can take as many as you want to of those, you're very unlikely to OD. It would have to be something else that would have to happen within that, like heart stopping related to some kind of precondition. But anyway, just understand that that GABA manipulation is there's a lot of problems when you start altering GABA. So with regards to benzo withdrawal, so we talked about them. We talked about taking all those in excess. So we also know that they're addictive, right? So we talked about earlier about in one of the videos about the glutamate and the GABA relationship. So you have a lot of glutamate, the GABA brings it down. If you actually take out the GABA, then you've got the rebound sort of sympathetic activity, you've got the rebound glutamate. So one brings you down, withdrawals you would expect them to bring you up, right? It's a depressant, so when you withdraw from a depressant, you go up. So things to think about neurologically: convulsions, insomnia, lightheadedness, involuntary movements, headaches, weakness, gastrointestinal nausea, vomiting, diarrhea, weight loss, decreased appetite, psychiatric symptoms could be irritability, anxiety, memory impairment, depression, confusion, and then other things are like tachycardia. So again, benzo is a parasympathetic. When you remove that, you take the braking mechanism off, you go up. So much like with amphetamines, that we had talked about in the other chapter, when it brings you up, then you get all of the things you get from sympathetic. When you come off of that, then you're going to have a lot of rebound sort of parasympathetic activity. So, sleepy, sort of no energy, sort of fatigued overall, difficulty concentrating, focusing, things like that. So just kind of keep those in mind in terms of the withdrawal effects. So some of the common side effects to benzodiazepines in general are going to be ataxia, confusion, depression, drowsiness, dysarthria, headache, impairment of mental functions, sexual dysfunction, skin reactions, weight gain. Again, sort of think about those parasympathetic things. So there's other medications outside of benzodiazepines, and I'll talk about. I don't want to cover them specifically because the PowerPoints do a very good job as we're talking about each one. The main thing that I would focus on is sort of the half-life, because that's going to sort of determine when you're going to use them and in what situation. In particular, for inpatient, if you're thinking about treating psychiatric condition, maybe extreme irritability or hostility, you're going to want to use a thing like Ativan or oxcarbazepine, Serax, oxapam, because it's shorter, and you don't want them to be on it for a long time, because it's not necessarily why they're taking the benzodiazepine, it's because they got irritated. You're looking for a rescue medication. Whereas if you're looking for something that someone that's detoxing from alcohol, when you know this is going to be sort of a longer process, you may want to use a longer medication, sort of like a Librium or a Valium or a clonazepam, which are going to be pretty effective for that. The other medications that you can use for sort of anxiety, and we talked about a few of them beforehand. SSRIs are really good in terms of treating anxiety and panic over a long period of time. So for panic disorder, SSRIs, sertraline, paroxetine are good medications. TCAs to a certain extent, but again, you have the dangers that come along with the TCAs. Agoraphobia, alprazolam is actually pretty good for that. TCAs, SSRIs. Social phobias, beta blockers are really going to be the main difference in terms of how you're going to treat the different anxiety disorders, and the reason being in terms of agoraphobia, and even to a certain extent panic. If you use things like beta blockers, and it keeps you, again, we talked about parasympathetic and sympathetic. Anxiety is a sympathetic response, so if you're using things like beta blockers or things like that, then you're putting a ceiling on the ability for your sympathetic to actually be aroused. So when you get anxious, your body starts to rev up. Well, blood pressure medications are designed to kind of keep that in check. So that's sort of why those work in those situations. And if you intuitively think about it, that's probably better for situations like that. I mean, agoraphobia is something that you're going to be, if you're in that environment and you have to go out to Walmart or something, you're agoraphobic, you're going to need something to kind of continually keep you from from going to that sympathetic state. And again, SSRIs and TCAs for long-term control are preferred as well, and actually in combination work pretty well. Obsessive-compulsive disorder, we had talked about that with sertraline and Luvox. And the post-traumatic stress disorder, I mentioned that in the depressant categories. Our video, rather, sertraline, high doses of SSRIs are typically used to do that. We don't really use benzodiazepines with PTSD. A lot of research came out that basically said, kind of what we already knew, that it's bad for the brain, it's bad for their ability to actually be able to get into therapy and actually formulate sort of new ways of dealing with things, because again, you keep everything down, it's hard for you to learn and process things effectively. One thing that you will see in people that are being treated for maybe anxiety is because you have the period of time that we talked about earlier between antidepressants and their ability to be effective, then you may see benzodiazepines prescribed for about 2 to 3 weeks, allowing the SSRIs to have full effect. If they're really in crisis, if the anxiety is in such a way that they can't do anything from day to day, then you may want to consider a benzodiazepine. But again, I would consider benzos to be more rescue medications more than anything else. That's what they were designed for. That's what they're effective for. And people's anxiety 8 out of 10 times can be controlled with an SSRI or something along those lines. And then going back to, you have other agents that are sort of off-label used for anxiety. Hydroxyzine or Vistaril is a pretty good medication if someone just needs sort of something for unpredictable anxiety. Maybe it comes and goes. Some people feel better about having just something that they could take. Hydroxyzine or Vistaril is pretty good for that. Gabapentin, which I had talked about in the chapter before, that I actually really like. I talked about how it manipulates GABA, same kind of thing. GABA works pretty well for anxiety because of its manipulation of GABA. Clonidine, again, for the sort of same reasons that I described about the sympathetic nervous system, the alpha 1 receptors, same deal. Let's see. There's a few different SSRIs that are approved for anxiety. Not all of them are. Most of them can be used. But Lexapro is approved for general anxiety disorder. The SRNIs, Cymbalta and venlafaxine, are approved for general anxiety disorder. And that's typically what you're going to see in the clinic, is going to be generalized. If you're dealing with the veteran population, you may see some phobias or some PTSD stuff, and you may have to use some of the medicines I had articulated earlier. But with regards to general anxiety, that's probably more or less what you're going to be sort of managing. So again, most of the SSRIs do pretty well in covering that. I think that's all for this one. Pay attention to, again, the PowerPoints and the readings. Much of this stuff here is pretty straightforward. Just know benzodiazepines and know sort of their overall function. I mentioned again with sort of alcohol withdrawal, DTs. Just think about anything that is putting GABA in the body, like barbiturates, like alcohol. The way you have to control that is by putting GABA back in and tapering off slowly. Again, think about the GABA-glutamate relationship in some of these decision-making, and I think that it'll be pretty effective. Again, if you guys have any specific questions, or if you guys want to talk about any of this stuff any further, you can reach me by email, chancen@uab.edu. Be more than happy to answer any questions you have, or you can reach me in my office at 205-996-9821. Good luck with the tests and your certification.